We're very pleased today to have with us Dr. Ann Gaglioti, and she is the Associate Director for Research at the National Center for Primary Care here at Morehouse School of Medicine. She's also the Director of the Southeast Regional Clinicians Network, or CERN, a practice-based research network made up of FQHCs, federally qualified health centers, and her clinical practice has been focused on the care of underserved and marginalized populations. So we're really glad to have Dr. Gaglioti with us. My name is Phoebe Nelms, and I am the Program Manager for the Quality Payment Program, Technical Outreach here at Georgia High-Tech. So, according to a CNN article that I read last month, the World Health Organization has included the CD11 section on problems related to employment. So, although anyone can experience burnout, today we're really going to focus on medical personnel, especially clinicians. We count on them so very much. And so we too have a privilege of supporting them and recognizing the many challenges they face in addressing this issue. So without further ado, Dr. Gaglioti, please share with us what you've prepared today.
Thank you so much, Phoebe. It's my pleasure to be here today to talk about this important issue that's really near to my heart. My path in medicine began at an academic health center where I went to medical school and attended residency. And although I got excellent training in those programs, there was not a lot of formalized training around how to care for myself as a clinician. Although I think where I did attend school at Case Western was on the forefront of developing some of that curriculum, and I did benefit from my teachers there. After residency, I became an educator myself, as well as a researcher. And what I noticed about my trainees was that they often struggled with their own development as a clinician, both professionally and personally. And so in 2010, I started developing some curriculum for medical students entering the clinical time of their rotations as a way to sort of help them make that transition. And since that time, physician wellness has been a passion of mine. Over the last 5 to 6 years, that physician wellness or attaining joy in practice has really become a national conversation as it's been listed in the quadruple aim. So what I'll share with you today is informed by research, but also my personal experience and path to finding fulfillment in my own practice. I wanted to start with a story, and I think this is one story of many. When I was attending at an academic health center as a faculty member, we had a really horrible incident occur. One of the residents at the health center was found one morning from a self-inflicted gunshot wound in the hospital parking lot.
Oh, no.
And he had a young family and really had a path of hope and promise in front of him to have gotten to such a privileged place as a medical resident. And to me, that was just really a personal call to say, you know, we cannot let this truly preventable illness occur, you know, in our own discipline, in our own profession. And I certainly have became more attentive to the national conversation around physician wellness at that time. I think many training programs and medical schools have responded to stories like this by really trying to respond and build curriculum. But as we do that, it's important to build a body of evidence So we're doing what's effective and what works. So I'm going to try to give you an overview today of really the landscape of clinician burnout and wellness currently. We'll talk a little bit about the factors that contribute to clinician burnout and wellness. We'll identify some of the symptoms and risk factors, and then we'll take some time to really explore some strategies that have been shown to be effective to promote wellness and reduce burnout. In 2014, Tom Baudenheimer and Christine Sinski really brought provider wellness into the conversation around the triple aim. They wrote a landmark paper that identified the physician workforce and the dissatisfaction and burnout that was prevalent in the physician workforce as a threat to achieving the triple aim. And so they said in this paper that we cannot really enhance patient experience, improve population health, or reduce healthcare costs if we have a physician workforce that is not well. And thus was sort of coined the term the quadruple aim that included joy in practice or physician wellness as an aim that was as important for our healthcare system as the rest of the triple aim. So I think it's important to define some terms before we move forward. When we talk about burnout, this is a syndrome or a constellation of symptoms that are defined by three main things. The first is emotional exhaustion. The second is cynicism or detachment or depersonalization from your work. And the third is a sense of low personal accomplishment or feeling like your work does not matter or make a difference. Traditionally, burnout is measured by a validated scale. The most well-validated scale is the Maslow Burnout Inventory. And this has really been, in the literature at least, what we have used as a yardstick for defining and measuring burnout. However, I think that it's important to recognize that burnout is one point on a spectrum of severity along, and that continuum starts with stress and really has its endpoints in mental health issues like depression and end-stage illness like suicide. And so we will talk mostly about burnout today because that's really where the literature has been focused. But I think it's important to remember that this phenomenon exists on this continuum of severity. Although burnout is sort of the measure that we have used most often, it's important to also be aware of other terminology for this issue. In the literature, they also discuss work-life balance, self-care, wellness, and resilience as terminology around this topic. A recent article that got a lot of attention from clinicians described burnout as a moral injury that has been inflicted by the healthcare system. And really that is something that allows you to, the system does not allow you to provide high quality care in the context of your work environment. And that causes significant distress for clinicians. So when we think about the landscape or the epidemiology of burnout, really this is a significant problem for the clinician workforce in the United States. More than half of physicians are experiencing one symptom of burnout in national studies. And this is really different from the general employed population. Physicians have twice the rate of burnout or experiences of burnout than the general population. And this data is really based on two national studies that have been conducted over the last decade or so. So it's not just physicians who are affected by burnout. the National Academy of Medicine, formerly the Institute of Medicine, has this nice infographic that highlights some of the other health professions. Specifically, primary care nursing has a rate of burnout that's between 23 and 30%. It's also important to say that this is not just burnout, but some of those other issues that are further along that spectrum of severity. So 39% of physicians are depressed, and every year 400 physicians die by suicide. And this is a significantly higher rate of suicide than the general population. In fact, it's twice as high. I think it's important to note that in the more severe end of that spectrum, as far as suicide rates, there are also gender disparities among physicians in particular. So compared to non-physician men or men in the general population, male physicians have a rate of 1.4 times higher of suicide. And for women, that rate is more than 2 times as high than the general population. We have an opportunity to intervene in this disparity and this epidemic of burnout early in training. The disparities that we note in suicide rates start early on in medical school, as does the higher prevalence of psychiatric illness. Physicians in training, because of their expertise, are more successful at attempting suicide than the general population, and are often not able to recognize symptoms of depression in themselves. When we think about things that both positively and negatively impact clinician well-being, it's important to understand that this is a multifactorial, multi-level problem. The Mayo Clinic has presented this logic model that explains some of the drivers and of both engagement and burnout. These include individual level factors like social support at home, work-life integration, finding meaning in your work. But these also encompass some system-level influences, like the organizational culture and values. And so these things can be optimized or not optimal, and the balance of these factors can play a role in clinicians' experience of burnout. The Institute of Medicine, or the National Academy of Medicine, also has this conceptual model of factors that is very similar to the Mayo Clinic's model. And again, they highlight those individual level factors and system level factors that have an influence. And so there's personal factors like gender, specialty, family environment. There's skills and abilities at the individual level. Things like, what is your experience in your training? What is your ability to sort of integrate difficult situations or respond to change? And then there are system level things like the rules and regulations that are enforced by the healthcare system payment infrastructure, and the organizational factors at your workplace and in your clinical practice as well. What I like about this model is that it has as central clinician-patient relationships and patient well-being, understanding that there really is a link between patient well-being and clinician well-being that's anchored in the clinician-patient relationship. I think that that interface has a lot to teach us about how we can find a pathway out of the epidemic that we're facing now. So the rise of clinician burnout and sort of the health crisis we're facing among clinicians, I believe, has sort of a broader context that we need to be mindful of, that there have been some climactic shifts in the healthcare landscape that frame this crisis. My brother is a climate scientist, and so he has shaped my thinking about these things. So we have to recall that the system that we are in overall has faced declining reimbursement, increased expectations for productivity, transition to electronic health records and health systems, increased consolidation of practices into employee, where clinicians are employees instead of business owners. There's a decline of small to medium-sized practices that I think has been coupled with less autonomy and less sense of autonomy as far as clinicians having ownership of that. And then the environment that Phoebe and her team know so well, this environment of increased measurement, pay for performance, quality metrics, patient satisfaction, that we are constantly being measured. Because of these climactic shifts, I think the reason that a lot of us went into medicine, which in my mind is
to help people.
Yes, to help
people,
the relational aspect has become less central. I love this paper from 1980 by Fox because I think it really sums up this compartmentalization of humanism in medicine. And so they make the point in this paper that healthcare delivery is really integrally connected with some basic and transcendent aspects of the human experiences. You know, we are dealing on a daily basis with birth, survival, growth, death, aging, mortality, and suffering. And so if we are not able to integrate those experiences as human beings and clinicians, I think that sets us up as a profession for being at risk for some of the symptoms of burnout.
It's almost as if there's an unrealistic expectation that you can be compassionate and giving, and at the same time maintain that emotional disconnect to be able to perform. So it's kind of a conundrum, isn't it?
It can be, yes. So I think that it is really important that we work to integrate that human response with the clinician response and to build those bridges between those two things. Unfortunately, that is not explicitly modeled all the time in our training. And sometimes formal instruction around integrating human responses with our clinical gaze, as Foucault says, those forms of instruction are compartmentalized themselves within medical education. Once we get out into the world, out of our training as clinicians, those forums to discuss these issues for integrating human responses with clinical responses are even fewer. And so I think one pathway out of this crisis is to really work to build those bridges. When we talk about who's at risk for burnout, there are some individual risk factors that are important to know. Women, for example, are at significantly higher risk for burnout than their male colleagues. And also frontline caregivers are at the highest risk. These include emergency medicine physicians, obstetricians, family physicians, general internists, and infectious disease doctors. Also, those at an earlier stage of their career are at higher risk for burnout. The impact of burnout has been very well documented in the literature. At the clinician level, risks of burnout include low work satisfaction, disruption of relationships in your personal life, increased risk of substance use disorder, and increased risk of poor mental health and suicide. At the patient level, patients who receive care from clinicians who are burned out report lower satisfaction with their care, have reduced quality of care, and are at increased risk of having a medical error occur in their care. At a system level, the impact of burnout is significant. Burnout often will cause clinicians to decrease their productivity or decrease their effort. It can contribute to high turnover, early retirement, and decreased quality that systems are prioritizing measurement of, as well as increased errors and poor patient satisfaction, which also impact how a system is able to perform. There's a very nice study recently that came out this June, actually, just a few weeks ago, that did a very nice analysis to estimate the cost of physician burnout in the United States. This is a costly problem. It costs the system approximately $4.6 billion per year. And at the organizational level, it costs about $7,600 per clinician per year. And this is based on the cost of the turnover and reduced clinical hours due to burnout. I wanted to touch on this a little bit because the terminology we hear is changing, but there's this shift from talking about burnout to discussing, framing it as a discussion around clinician wellness. And this is a great concept, sort of a positive deviance or appreciative inquiry approach. However, the science behind measuring physician wellness is not as robust as the science around measuring burnout. Brady et al. Did a nice article in Academic Psychiatry last year. They conducted a meta-analysis of measures of physician wellness. And what they found was that actually most of these measures emphasize burnout because that this was something easy to measure. And that there was also not consensus between researchers around what the definition was for clinician wellness. And they called for consensus around defining wellness as well as consistency in measurement so that the science around promoting wellness and not just preventing burnout can be advanced. They also proposed a definition for physician wellness in this study, which I thought was very nice, and so I'm including that here. They defined physician wellness as quality of life, which includes the absence of ill-being and the presence of positive physical, mental, social, and integrated well-being experienced in connection with activities and environments that allow physicians to develop their full potentials across both personal and work-life domains. And so that seems like a lofty goal to me, and reminiscent of actually the WHO definition of health that hasn't changed in many, many decades. So I think when we think about building paths to clinician wellness, now that we've sort of looked at the landscape of the problems that we face with clinician burnout, when we think about building paths to wellness, we have to be mindful that this multi-level problem is going to have multi-level solutions, and also that the solutions need to be directed at the appropriate target. I think there's been a lot of pushback from clinicians recently because there's been this conversation nationally that individual self-care by physicians should address the system-level causes of the clinician burnout crisis. And that's actually been shown not to be true and can also potentially burden providers who are already overburdened, who now have one more thing to do.
I really like this illustration because we do want to encourage wellness for everyone, and today especially clinicians. But that illustration of putting the responsibility on the clinician can feel like a burden. It's like asking the driver to fix all the potholes in the road.
That's a great analogy, Phoebe. I like that. Yeah. So system level and structural change cannot be addressed by individuals working alone. So I think as public health professionals and clinicians and primary care providers in particular, we are great at framing health issues in a multi-level framework. So this is the social ecological model of healthcare that sort of contextualizes an individual in the context of their interpersonal relationships, the institutions where they function, the community where they live, work, and play, and the broader policy environment. The Mayo Clinic has really been on the forefront of moving the science forward around burnout and physician wellness. And they have a landmark paper where they defined these drivers of burnout and engagement that I discussed with you earlier. They also really nicely define that each of those drivers has multiple levels of influence. And so that there are individual factors as well as national factors that impact workload and job demands. And so while this slide may seem overwhelming, I actually think it's a great illustration because it shows us that there are a myriad of opportunities to impact physician engagement and clinician wellness. That we have all these levers at our disposal to make a difference in this crisis. And some of those can be done at the individual level. But that there are also things that we can do in our practices, in our healthcare systems, and from an advocacy perspective that can move the needle. So in the second half of the webinar, I'm going to discuss some evidence-based approaches that have been shown to be effective. One thing that has been shown to be effective at the individual level is to really address skill building for primary prevention of burnout early in the clinician pipeline. That can be done well through explicit modeling and mentorship around wellness from medical school faculty, as well as integrating curriculum into the health professional education. So it's available to all students regardless of who their faculty or mentors are. One intervention that's shown to be particularly effective is something called compassion cultivation training, where medical students learn to have compassion for others, but also learn to have self-compassion. And this intervention allowed them to perform better clinically, but also improve measures of their wellness. And so to me, this is a win-win opportunity for both patients and the future workforce. As we were alluding to before, individual level interventions are important, but have not been shown to be impactful in a vacuum. And so there was a nice meta-analysis that looked at controlled interventions to reduce burnout in physicians in 2017. And it showed that there was a very small impact of individual level interventions if they were done at the individual level alone. That really what was needed was a multi-level approach. And so that these interventions had to be embedded within the organization in order to be the most successful. Not doing that could potentially, as we discussed, lead to increased clinician burden and a sense of failure and self-blame that they, for one's own burnout, that one was responsible for that experience because they weren't strong enough personally to prevent it. So what can we do at the organizational level that impacts clinician burnout? In this meta-analysis, one of the most successful approaches was to create space for communication between both the members of the healthcare team and also for individuals on the healthcare team to have spaces for communication with the organizational leadership. In order to do this, you really need an organizational leadership that recognizes and prioritizes the importance of clinician wellness, and who's going to sort of make the structural change needed to create those spaces for communication, for two-way communication, to have positive impact. Another organizational level approach that has been shown to be really effective is to promote autonomy among clinicians to address workflow problems that they feel are negatively impacting their burnout level. So providing the structure for clinicians to provide input on workflow solutions and to translate those solutions and test them and measure the success of them and scale the implementation of them is what can be done on an organizational level to address clinician burnout. Yes.
And that's one of the services that ga-hitec provides to actually assist in defining workflows that are more conducive to reducing the burden that some clinicians feel from using the EHR. And so, we're really thankful that in that small way, we are trying to support clinicians and ease their load and make it more effective and efficient for them.
That's a wonderful service. I really, I wanted to share this paper as well. This paper was done by colleagues at the American Board of Family Medicine and University of Washington. And I think it is an intervention that can be impactful at both the individual level and at the organizational level. What they found was that early career family physicians who are at particular risk of burnout because of their early career status, who had a wider scope of practice, had lower rates of burnout compared to their colleagues who did not have a wide scope of practice. And so early stage family physicians who are providing outpatient care, obstetric care, home visits, inpatient care, were actually less burned out than their colleagues who were only doing one of those things. And I think that, comprehensiveness is one of the aspects of primary care that has been shown to positively impact health outcomes on a population and individual level. But here we see that it's also impactful for clinicians. And so I love that it's sort of a win-win. So I think this is an organizational charge, I think, to really have organizations who are employing family physicians who are the third most burned out specialty, to devise mechanisms that support comprehensiveness of practice, and to create positions where physicians are able to, provide the scope of practice that they desire to provide.
The old axiom, variety is the spice of life.
I like that. I think in our reductionistic society, we often think that doing one thing well is better for you. But this is a really nice study that shows that that is not that is not the case. When you have a generalist physician who is trained to be a generalist, they thrive when they are practicing as a generalist. I wanted to share just some practical wisdom that I've shared with learners on what we can do as clinicians to practice self-care. Because I think that while structural change is needed, we still need to build our own practice of growth and development as individual clinicians. There was an older qualitative study done in 1990 looking at physicians' approaches to stress. And there were 5 elements of effective self-care that were identified in this study. One was a sense of self-awareness. The other was sharing of feelings and responsibilities. The third was self-care. The fourth was developing a personal philosophy. And the fifth was reframing and limit setting. So I've taken these elements and tried to make them practical and applicable for the frontline clinician. So I think as healers, from a practical perspective, we need to understand and have an awareness that our job presents specific challenges that require constant attention, that we need to constantly be reflecting on our practice and thinking about how our patients' experience impacts our experience of the world. We need to think critically about how we process the emotions that come up in our daily practice. We need to have a way to deal with that. And we need to maintain our own sort of ability to look critically at the world and understand how that affects us interpreting our patient's narrative and also impacts our ability to be present with compassion for ourselves and our patients. I explicitly tell medical students and residents that they need to care for their bodies, that they need to eat and exercise well. They need to avoid toxins. They need to build in time for rest as well as sleep, and they need to attend to their own medical care. I think sometimes having someone, a teacher or a mentor, explicitly tell you these things can be powerful and provides that explicit modeling that we were talking about earlier.
And I guess that explicit guidance, if given when they're early in their career, in their career as a student, and then it will hopefully transition with them into their practice and begin to really shift the balance that they strive for. And they're driven people, but they would need that balance in order to maintain a longevity of practice.
Yes, balance and boundaries. Absolutely. And these reminders are helpful for me in my current practice. It's always good to be reminded of these things. I tell my learners that they need to have relationships with things outside of their clinical work, and to remember who they were before they became involved in medicine or the healthcare system, to understand what brought them joy at that time and what they valued, and to cultivate the relationships with those things. I also tell them that it's important to devote time to caring for your relationships interpersonally with your family and with people who are important to you, and to be mindful of not using work as a shield. It is easy for us as physicians or clinicians to hide behind our work and to use it as a way to keep from getting engaged in our relationships. And I think it's important to be mindful of that. And I also emphasize the importance of cultivating an internal life, whether that's through religion and spirituality, mindfulness, or journaling. That it's important to have some practice that allows you to reflect on your medical practice and your practice as a human being, and to integrate those things. The last thing I think is important, for me as in my own professional development and growth, has been cultivating meeting at the bedside with a patient, and to really sort of hold that as a sacred space that we have in our exam rooms, I always tell people when you close the door and it's you and the patient, that really is a sacred space, and you are creating that together. And that there's power in having someone tell you a story, having that story be heard and reflected, and reflecting meaning back to a patient through our paradigm as healers. And so being able to be mindful of that, and also being mindful of the meaning that creates for both the clinician and the patient. Because I think having that meaning is certainly protective from burnout on an individual level. As we close here, I just wanted to give you some tools to have in your toolbox. I'm just going to highlight a few, but if you go to any one of these resources, you will find yourself down a rabbit hole of great tools. And so I encourage you to explore them. The American Academy of Family Physicians has a platform called Physician Health First. It allows you to assess your burnout level, create a plan, and they also host a conference annually where you can build community with other physicians and clinicians in family medicine. The Mayo Clinic has also developed a great tool for clinicians to assess their well-being. What I like about this tool is that it is tailored to multiple different roles of clinicians. And so there's a physician assessment, there's one for residents and fellows, one for advanced practice providers, one for nurses, and one for healthcare system employees. And so I really like the inclusiveness of this tool and its focus on measuring well-being. As far as organizational resources, I pulled a few great ones. The National Academy of Medicine, formerly the Institute of Medicine, has a clinician well-being knowledge hub. And so that includes resources, their conceptual model, the research clearinghouse, and courses that are available. And so I think that this is a great resource for anyone interested in learning more about this topic. Finally, as I referenced several of the Mayo Clinic resources, the Mayo Clinic program on physician well-being has authored this very helpful paper called Executive Leadership and Physician Wellbeing, 9 Organizational Strategies to Promote Engagement and Reduce Burnout. And these are on the left side are the 9 strategies. And so they give a deep dive into each one of these strategies and really give you some tools to operationalize these recommendations. And so I highly recommend this as a resource. It's been a real pleasure talking to you all today. Phoebe, thank you for having me, and I'm happy to answer any questions.
Perfect. So thank you so much, Dr. Gaglioti. That was a great presentation with loads and loads of great information. What we're going to do now is open up our chat and our Q&A for any questions or thoughts or responses to our presentation. Right now, we do have a few questions that have come in. It looks like we have is burnout in medicine really more than other fields, or just talked about more?
Thanks for that question. Yes, as I alluded to early on in the presentation, physicians in particular experience burnout at a rate about twice as high as the general employed population. And so burnout really is more of a problem in medicine than it is in the general employed population. And burnout is traditionally a problem that's faced by people in helping professions. And so we also see this in other helping professions, teachers, first responders, et cetera.
Makes sense. We also have another question that just came in. Have you looked at studies to see what the burnout rate before EMR and after EMR is? Many providers that I talk to say that the computer work is what is driving the most stress.
I think that, that intuitive guess that you have around EHRs being a contributor to burnout is probably a good one. But I think that this is a much more complex and multi-level, multifactorial problem than simply the influence of the EMR. I think these conceptual models presented by the National Academy of Medicine and the Mayo Clinic both speak to that there are individual level factors, system level factors, and policy level factors that are really at play here. And just in addressing one of those problems or influences is not going to solve the overall epidemic that we are experiencing.
Yeah, so there are those who definitely feel that burden of actually documenting everything. And then there are those who actually view it as a very helpful tool because it helps them to target identified populations, and they're able to use that tool if the workflows and the functionality and usability of their EHR system are optimal, then they actually find it's a blessing and redeems time for them. So there's certain, as Dr. Gaglioti mentioned, specific and internal to each organization and each practice contributing factors. So some love it and some hate it.
But I think one thing that really has been shown to be effective at an organizational level is to integrate and give clinicians an opportunity to have input into those workflows and adjusting those workflows to allow a structural mechanism for physicians to have some autonomy in that space.
One of the things that we try to do to support clinicians, of course, because our role is for the state of Georgia to help them with the quality payment program and also the Medicaid EHR incentive program, is to help them have those conversations with their EHR vendors and also make sure that it is optimal to them achieving success in their participation with those programs.
Thank you. We had a couple more questions. How should you instill a new sense of purpose for a fatigued clinician? That's a good question.
It is, and I think it really depends on where that individual is at along that spectrum of severity. And so, while a clinician who is stressed might benefit from one intervention, a clinician who is severely depressed or suicidal clearly needs another approach. And so I think really knowing where you're at as far as burnout or along that spectrum of burnout is really important. And I think that AAFP has a great resource for assessing that burnout. So first is getting an accurate picture of where you are, and then second is designing sort of the appropriate intervention based on the severity of that experience. And again, that intervention is likely going to need to be a multi-level intervention. So it's important that the clinician has the support of their practice and organization to discuss that and also feel supported structurally in addressing those issues.
And I think that on an individual level, I'm a patient, I have a provider, and so this information has really made me much more aware of doing what I can to express appreciation and, complete communication with my provider, because we just expect them to take care of us. But even though it's expected, how wonderful for them to receive that acknowledgement and expressions of appreciation for what they do that really has a tremendous positive impact on our lives. So even, just as the average citizen, so to speak, we can also impact clinicians' job satisfaction by giving them that positive feedback and expressing it.
That makes me think of a story Dr. Gagliotti told us about the eggs that really stuck with me. Can you share with us that story?
Sure. I think, Phoebe, you're right that those expressions of appreciation, even if they're small, really do bring meaning to our work as clinicians. I had patients in Iowa who every time they would come see me, they had chickens and they'd bring me a dozen eggs. And it was just such a wonderful expression of kindness, and that still makes me smile. So I think that's a great and understudied sort of aspect of this problem is, how can we improve the space for that patient-clinician relationship to support both the well-being of clinicians and patients? And sometimes that's hard to do in the context of a 15-minute visit, and it's hard to do when you're staring at a computer screen. And so what are those structural changes that need to occur to make that space ripe for that type of interaction?
Well, shifting gears a little bit, we had a question come in from registration that asks, what are immediate skills to address workplace distress in the moment, as well as preventative practices specific to practice?
So I'm not sure. I'm not sure exactly what that question is getting at, but I will do my best to answer. I think skills to address distress in the moment. One of the great skill sets that I've been fortunate enough to learn is mindfulness-based stress reduction. And so being able to sort of have an observer perspective of an unpleasant situation when it's happening, to be able to respond to that situation instead of reacting to it, and to be able to control my own emotional reactivity around that incident has been very helpful. So I think that I would recommend that, building those skills for anyone who works in healthcare and anyone who lives on the planet Earth. But as far as preventive practices, I think that, when we talk about primary prevention of burnout, we really need to catch folks early in the clinician pipeline, because these symptoms do develop early on. And so our opportunity for primary prevention has to be pretty far upstream.
And your presentation was so very practical because you did touch on so many levers. I love that word you used, levers to make a difference. And so our objective in producing this particular topic with you, thank you so very much, is to increase the awareness that you can use those levers to make a difference for whoever the individual clinician you interact with is. And also organizationally to gather input from the clinicians who will be impacted by the decisions that are made organizationally, to empower them to influence how things are structured within the organization.
And I know we spoke on a level of a practice, but what about individually? How does someone stay happily engaged with the work of helping people heal?
I think that those practical sort of pointers that I closed with are really helpful for me on an individual level. But what helps me most is, having that time at the bedside with my patients and connecting with them authentically. Because if we can connect, around that meaning making of, sharing narratives of experience, and that is really the key to helping people maintain a healing practice for a long time. And oftentimes in medicine, we let other things get in the way of that relationship. And so I think the key is to, on an individual and organizational and policy level, structure that space so that healing and meaning can occur.
Okay, great. Well, we don't want to hold everyone too long, but if you all have any additional questions, please feel free to email either Dr. Gagliotti or Miss Phoebe Nelms at the emails that are on your page right now. Again, we want to thank our speaker so much for coming and giving us this wealth of knowledge, and our moderator as well for sharing her viewpoint. And we want to thank you, our participants, for coming and joining us. And we have some additional resources if you want to look a little deeper and check some things out for yourself. And this information will be available at a later time on our website. Again, thank you so much and enjoy the rest of your week.